I read, the more I read, the more I know, the more I know.
Cardiogenic shock is one of those things that trip up students, and it doesn't really need to. We know that shock is the body struggling to move oxygen from the lungs to the tissue, and if it's a problem with blood volume, it's because of hypovolemia. If it's a problem with blood vessels, it's distributive, but we're just talking about cardiogenic shock, which means that the heart is either not pumping enough blood with each beat, or it's beating too slow. Either of those are going to lower the amount of blood that the heart moves throughout the course of a minute. That number that we're talking about is cardiac output. And if we're going to understand cardiogenic shock, we need to take a step back and kind of break down cardiac output. Cardiac output is really just stroke volume, or the amount of blood that the heart moves with each contraction, times the heart rate. If we multiply those two numbers together, we figure out how much blood the heart's moving over the course of a minute. You take a normal stroke volume of 70 and you multiply it times a normal heart rate of 70, you end up with 4,900 milliliters of blood moved over the course of a minute. Now, if you took that same patient and you said, hey, they had a heart rate of 20, you would only have a cardiac output of 1,400, way too low. That patient would be in cardiogenic shock. Because again, that's really all cardiogenic shock is a low cardiac output. So we know that if either stroke volume or heart rate decrease, cardiac output's gonna go down. We got cardiac output. We understand that it's stroke volume times heart rate. And if either of those decrease, cardiac output's gonna decrease. So what factors affect stroke volume and heart rate? Well, heart rate's simple. Any EKG abnormality can make the heart rate go super high and decrease that preload time, or super low and it'll decrease the cardiac output. Now, stroke volume is affected by two factors. One, back to preload, how much blood goes in the heart before it contracts. Obviously, the more blood that's in the heart when it contracts, the more blood that's ejected. The less blood, the smaller the ejection. The other thing is how hard it can contract. The harder the contraction, the more blood that's ejected. So what conditions can lead to cardiogenic shock? Well, we got, on the stroke volume, we really have two sides that we have to concern ourselves with. Congestive heart failure, which I'm way oversimplifying, and that deserves and may get a video on its own. But for right now, we're just going to say congestive heart failure, the heart is too weak to cause a decent amount of blood to be ejected from the heart. The other thing is a heart attack. Obviously, if a large enough chunk of the cardiac cells are dead, the heart's not going to be able to pump effectively, and that's going to lower stroke volume. Okay, so we understand that cardiogenic shock is low cardiac output, which is the byproduct of stroke volume and heart rate, and one of those are decreased. And congestive heart failure, MI, or EKG abnormality can cause that cardiac output to drop, therefore putting the patient in cardiogenic shock. All right, I need you to calm down a little bit. I understand you're excited. You understand what cardiogenic shock is and how it's related to cardiac output and the conditions that can cause it. But our old friend National Registry, as of April 7th, 2025, is going to take this format and get rid of it. And they're going to have this new format for you. And I want you to be successful on the test and on the streets. So what we're going to do is we're going to continue on with this video, and we're going to go over primary and secondary assessment and treatment and transport of the cardiogenic shock patient. Nothing will kill a patient faster than a problem with the ABCs. That's why it's called the primary assessment. Every patient gets it, even the cardiogenic shock patient. Now, the airway management isn't going to be that much different than any other patient. Head tilt, chin lift, and use whatever adjuncts you have available to keep that airway open. The one thing you will see that's different is something called pink frothy sputum. Now, this is pretty rare in the field because it's such a late finding, but National Registry likes to bring it up a lot. What happens is, because of the cardiovascular system backing up, blood starts to leak into the lungs and it mixes with the air and the saliva, and then the patient starts to cough up this pink fun foam, and it's called pink frothy sputum. Now, you're going to suction the airway just like you would any other patient that had liquid in their airway. But the problem is it's down in the lungs, in the bronchioles. So when you transition over to the B in your primary assessment, and you listen to lung sounds, you're going to notice some really wet lung sounds, rhonchi and rales. The patient is not going to want to lay flat. Now, you might be tempted to put the patient on CPAP at this point, but I want you to hold off on that, and we're going to talk about why when we get to the secondary of treatment. For right now, all we're going to do is put them on high flow oxygen, so if any air is getting down through the alveoli, it has 100% oxygen rather than just 21%. Then you're going to move over to the circulation. Now, you're not trying to get the exact heart rate during the primary assessment, but what you can do is you can figure out if it's super fast or really slow, and you can kind of start to develop an idea of whether this is a stroke volume problem or a heart rate problem. You're also going to notice that the skin is cool, pale, and diaphoretic. That's because the body's trying desperately to keep the vital organs perfused, so it's cut off blood flow to the skin. And if you don't have blood in the skin, it's cool, pale, and diaphoretic. Done with the primary assessment, and this is not the patient you want to sit around and dilly-daddle on scene with. They need ALS care. They need medications, cardiac monitor, maybe some medicine. You don't know. But if you have a medic available, they can provide that treatment en route. You may need to rendezvous with a medic, or you may just need to hurry up to the hospital. Every service is different, but they need an either nurse or a medic to try to treat some of these symptoms, and ultimately a cardiologist to help get them better. So we're going to get vitals, but keep in mind the patient's in cardiogenic shock. So the heart rate could be anywhere. It could be really slow heart rate causing this. It could be a really high heart rate causing this. It could be a really high heart rate trying to compensate. There's no standard heart rate for the cardiogenic shock patient, but blood pressure, they're in shock. So we know that in the cardiogenic shock patient, their blood pressure is starting to drop. This makes it tricky. These patients are very difficult to treat because a lot of our go-to treatments like CPAP, nitroglycerin, IV fluids, they can be contraindicated depending on your patient's condition. So they're very tricky to treat. So with this low blood pressure, you think, James, let me just give some fluids. Well, if their lungs are full of fluid, we can't administer any fluids to bring up their blood pressure. And as far as CPAP goes, most services are going to have a contraindication for CPAP in cardiogenic shock. And the reason being is the blood pressure is low, but when that air fills up the lungs, it smashes the vena cava. And remember that preload from earlier in the video? It lowers preload, so it's going to lower your stroke volume. So you want to be very careful with the CPAP. You want to give oxygen a good chance to work. Now, there are times where you have to pay that price and you might have to put the patient on CPAP, but I'm definitely suggesting that you start with the oxygen. The other thing advanced EMTs and paramedics like to give these patients are nitroglycerin. It lowers the pressure in the pulmonary vessels, which allows the blood to drain from the lungs. The problem is, one of the big contraindications of nitro is low blood pressure. Most of your cardiogenic shock patients are going to have a low blood pressure. Otherwise, they're just having heart problems. It's not technically cardiogenic shock. So you can see where it can get tricky. Our normal techniques for raising blood pressure are kind of taken off the table, and our normal techniques for forcing that fluid out or getting that fluid out of the lungs is taken off the table. That's not to say it's never done, but it's done with consideration for the patient's overall condition. Congratulations, you now understand cardiogenic shock at the EMT level. You learned it's really not that complicated. It's just a low cardiac output, and cardiac output is nothing more than stroke volume times heart rate. You also learned the conditions that can drop the cardiac output, and we reviewed the primary and secondary assessment as well as treatment transport of this patient. If you have any ideas for future videos you want covered, leave it in the comment box. Until then, I'm going to try to get some sleep before the bell goes off. You stay safe.
The less I sleep, the more I read, the more I know, the more I know.